All right, everyone. Welcome back to Chiro Shift, the podcast that will change your perspective of the chiropractic profession. I'm your host, Dr. David Newton, and today I'm joined by someone that has been a leader within the profession for several decades now. He's engaged in research, been the team chiropractor to the LA Clippers, consulted for teams like the Arizona Diamondbacks and Seattle Seahawks, as well as Exos, a performance center located in Phoenix, Arizona, that is one of the most well-known and respected in the world. He's also the founder of First Principles of Movement, where he educates other clinicians by promoting health span and preventing disability by addressing the worldwide inactivity crisis. He is someone that has always held my deepest respect. Dr. Craig Liebenson, thank you for being here and welcome to the show.
Thanks, David. I appreciate that.
Yeah, of course. So let's hop right into things. As you know, I've been following you since school, which was back in 2010 is when I first began chiropractic school. And one thing that I can say that has always impressed me the most about your work is your ability to grow and change and shift perspectives throughout your career as new information becomes available. Now, we know the chiropractic profession in general has a hard time doing the same. From your perspective and from your opinion, why do so many practitioners struggle to implement current information into practice?
Great start. I love that. I'm looking out my window here. I'm in Venice, California. I'm staring at the fact that the fog has kind of burned off and there's blue sky and palm trees. And all I can say is I see blue skies ahead. I don't feel that we need to dwell on the past. There are reasons historically why chiropractors in particular have had to fight tooth and nail for their beliefs. It was part of their survival. They were put in jail for practicing medicine without a license. And this is on the heels of the era where medical doctors were using leeches and bloodletting, and chiropractic was part of, if we go full circle, a more preventive approach. That being said, of course, chiropractic, to survive, doubled down on an identity around the high velocity, short amplitude thrust, or what people call, getting your back cracked or spinal adjustment, et cetera. And we know that that is as good as anything else when it comes to musculoskeletal pain, especially spine pain. They were not far off from the eventual science. In fact, it turned out the U.S. Army in the 40s had thousands of case studies showing the validity of chiropractic manipulation versus things like anti-inflammatories, injections, surgery, etc., bed rest prescription, and most forms of physical therapy. And then, of course, we had an antitrust suit in, I believe, the 70s, settled like in 1980 or something, where it turned out the American Medical Association and the American Hospital Association had conspired to monopolize healthcare. And part of that was an antitrust violation against the chiropractic profession. And then lo and behold, we see think tanks emerge, put together by none less than the RAND Corporation, and they found that spinal manipulative therapy was, in fact, pretty efficacious. Now let's go forward. Okay, let's go forward. We now realize that all passive cares and medications and modalities and injections and things like that are not really what we would call the most person-centered or evidence-informed approach. And so we have to keep changing with the times. We have to update our priors. And we've learned that self-management is very important from a psychological resilience standpoint. And to teach people what to do for themselves is the ultimate rehab, according to my mentor, Dr. Carol Levitt, a neurologist from Prague. So, I took that to heart in my formative years, and always wanted to kind of learn what the science was saying. And I was lucky to come along at a time when things were turned on its head. At the very moment chiropractic was legitimized by these antitrust suits and the RAND Corporation. B, number two, it turned out that active care was shown to have special advantages where you teach people what to do for themselves over passively administering to people. And of course, the chiropractor sees that, people feel better, they're smiling, they're happy. So they want to stick with the things that work and keep their doors open and give them a career. and they're valued in their communities for that. And evidence-based uh, physios and chiros have kind of lost the narrative. The real narrative is person-centered. And I think we now realize, we look at the effect sizes statistically about different treatments for common problems like back pain or headaches or neck pain, et cetera. There really isn't anything that's better than anything else. So let's first just do no harm. It's the Hippocratic Oath. And that, again, is why self-management is so important. Empower people. If they have an affinity or a preference for dry needling or chiropractic or massage, I'm not standing in the way. These things are not bad. But let's also give people an experience about the safety of physical activity, because the biggest ask of all, what I'm most excited about, David, is that musculoskeletal pain is not a dread disease or diagnosis. Being told you have degenerative arthritis of your knee, a bulging disc in your spine, a pinched nerve, sciatica, these things tend to recur, yes, but they also tend to resolve. Recur means they resolve. And we want to spur the resolution, and we want to use this as a silver lining to help people to appreciate that the world has stopped moving. We are in a unique position. We are ports of call. We're gatekeepers for shepherding and stewarding people's relationship with movement. And the world has stopped moving. And we've gained weight and we've become pre-diabetic or diabetic. And what this is doing in a time when lifespan has lengthened is it's left us with a gap where our health span stops around 65. Our lifespan continues because of medicine to 85. And we're left with that 20-year period where we're not functionally doing things that are of value to us. And I think that's where chiros and physios have their greatest utility, is in using the pain episode as an opportunity to help people realize, hey, let's get you moving. Not every hurt equals harm. And you'll have the fringe benefit of lowering your biological age, building some lean muscle mass, enhancing your aerobic capacity. So when you're 70, you're less likely to be at a fall risk. When you're 80, you still have mobility to walk and to travel and hike and to go to Asia or Europe or do whatever you want. And at 90, you can avoid being in assisted living. So that's what I'm passionate about, David.
And I can tell just by listening to you talk all the time, the passion that you have for what you do and for sharing that message with other clinicians, with your patients, with the general public. That passion just exudes from you. And I think that's one of the reasons why you have been so successful in leading other chiropractors and leading other healthcare practitioners in this change that we're looking for. And I very much agree with you in the sense that the blue skies are ahead. I think both you and I could agree that we're seeing more and more young practitioners who are excited about this, who are going into school for these reasons and not so much because of the traditional narratives that tend to surround this profession. And I think that's something that is incredibly exciting. And I want to touch base on a few of the points you made there, because I think all of these things deserve some time to be discussed. And then the first thing I want to go to was your mention of health span and how that differs from lifespan. And one thing that I know you often talk about is that you want people's health span to last their lifespan. And if you could go a little bit further into that for our listeners, because I think this idea of health span is still a little bit new and probably not everyone has heard of it. What does it really mean? And I know you talked about being able to do things as you age, but if you could go a little bit further into detail on what it is you're really talking about when you're referring to the term health span.
Yeah, so it used to be about 100 years ago, the average lifespan was about 65. And people after the age of 65, we always had people that were outliers. We've always had centenarians. 3,000, 4,000 years ago, we had centenarians, but we just didn't have the population we have today. And we certainly didn't have the percentage of the population that made it that long. Today, the average lifespan is up from 65 to 85. Yet, we have more childhood obesity today than ever before. We have more sedentarism in 30-year-olds than ever before. We've gone from 1% diabetes rate, type 2 diabetes, to 10% diabetes rate. We have adult onset diabetes in children. Think of the name, adult onset diabetes. That means it didn't really exist in kids. Now it's very common in kids, as is childhood obesity. And about 50% of children by the age of 5 are not meeting the physical activity guidelines. The World Health Organization just gave an update from a meta-analysis about whether or not we're making progress towards stemming the tide of the worldwide inactivity crisis. And they had made a projection that they wanted to lower the rate of sedentarism to about 20% by 2030. They now have admitted failure. They say we're not going to. It's going up still. There are pockets of improvement, like in parts of Europe. And so we have to ask ourselves the question that you're asking. Okay, how are we defining the problem, first of all? So I think I've given you a little bit of the definition. What happens is if you are overweight, if you are sedentary, if you have pre-diabetes, not even diabetes, what you are is you are in an inflammatory state. And in an inflammatory state, your health span is compromised. Your health is compromised. You are pro-inflammatory. You don't use insulin very well. You're not regulating it very well. You don't have energy. The things that lead to that are things that socially are social justice issues, because it's not a level playing field. Not everybody can hire a personal trainer. Not everybody can pay for programming for this. Not everybody's going to see a healthcare professional like you or like me who's going to educate them about this. There's a lot of people that if you have pain, they're just going to look at it as a transactional situation, and they're going to do a scan or an x-ray. You're going to learn that, oh, I have degeneration, I have wear and tear, oh, I need to rest. They're going to get the wrong narrative, and it's going to feed the problem. So health span is something which really is all about a person's quality of life. It's about their identity. What are the things that you were doing when you were 30, 40, 50 that ideally you would like to continue doing into your 50s, 60s, 70s, and beyond? If you're jogging, if you're walking, if you're hiking, if you're playing tennis. And we know, as an example, tennis is one of the best things in the world because it works the body in so many different ways. Stopping and starting agility, it works your cardiovascular system. So we never want to tell a person that they have something wrong and they need to rest or protect. People intrinsically are going to rest and protect. We don't need to have them rest more and protect more. That leads to overprotection. And as some would say, we over egg the pudding. And now they have a nocebo. So health span is the most exciting space. The medical language for this, the disability language, is NCDs, non-communicable diseases. So what are NCDs? NCDs are the number one cause of disability in the world. NCDs include low back pain, neck pain, knee pain, cancer, heart disease. These are all NCDs. Some of them will also kill you, like cancer and heart disease. So the number one countermeasure, it's so simple. It's help your cardiovascular system, because the number one thing that's going to affect you is poor cardiovascular health, poor aerobic capacity. And so we have a saying, hashtag JFW, hashtag just effing walk. And that's number one. It greases the gears. It keeps you in the game. It helps your joints. And if we look at something like running is much harder, but the narrative is corrupt. People are told, well, you shouldn't be running. It's bad for your knees. You're too old. Well, if we look at the science, we just science the shit out of it. If I speak clearly, if we science the shit out of it, there are people who are marathon runners and they may have more degeneration, but people in the middle, recreational runners, have less degeneration than sedentary people. So there's a sweet spot, and that's really what I do. I know what you do, David. When we see people, we Goldilocks them. We find the sweet spot. We reassure them that A, not every hurt equals harm. B, your image isn't who you are. It's just one of about a dozen factors. Uh, and that the motion is the lotion. And these are things that we've known since the 1980s. And this message has just not gotten out there. As orthopedic surgeons continue to do surgeries, 84% of orthopedic surgeries aren't better than conservative care. As wealthy people keep seeking stem cells and PRP and other biohacks, as chiropractors keep chasing a quick fix and a mechanical solution to a biological problem, we're missing out on the huge opportunity of this aging population and how to help their health span meet their lifespan.
Yeah, and I would absolutely agree with everything you just said there. And as you start to talk about some of these other topics that I think a lot of people might not necessarily associate with chiropractic care, despite many of these things being within our scope and things that we're able to address within our patient encounters, right? So from your perspective, why is it that chiropractors might be such a good fit to take on these tasks? Because I really do believe that there's an opportunity in the way that we operate as a profession. And I know this is a big question, but I do think that there are unique aspects of the chiropractic profession that maybe allow us to tackle some of these issues in a way that might not be as well addressed in other settings. So, setting you up with a big one here. Very interested to hear
I
your
love it,
thoughts on
David.
this.
I love it. I don't think there's a difference in chiro and physio, or at least there shouldn't be. There is, but there shouldn't be. Today, if a consumer can tell the difference between a doctor of physical therapy and a doctor of chiropractic, I would say that that chiropractor or that physiotherapist is not at the cutting edge. For the person-centered chiropractor or physio, rehabilitation is training in the presence of injury or pain. This is an agnostic approach. Nobody has ownership of this. And we know that self-management is at least as valuable as any of the modalities of care. And chiros and physios both can apply all the modalities of care, from dry needling to soft tissue manipulation to mobilizations of the joints to adjustments. So there's really no difference. But I think both professions are well situated as ports of call to do something that the medical profession actually is less suited for. The medical profession's reimbursement really limits their contact time. And we need to have more contact time because we're talking about the hardest thing to do. We're talking about behavior change. The game is the game of behavior change, according to Lorimer Moseley, a PhD and a physio from Australia. What we're trying to do is help the World Health Organization address the worldwide inactivity crisis. So this is a big ask. And in our sphere, again, the silver lining is that people come in for musculoskeletal pain. Musculoskeletal pain is recurrent. We can help shorten it. We figure out what they want, what they expect, what their preference is. We give them what they want. But while we're doing that, we also expose them to what's called graded exposures of different forms of movement, active movement. It's a behavioral experimentation. And we identify a safe starting point for them where we reassure them and reactivate them. Those two things, reassurance and reactivation, these have been known as evidence-informed or evidence-based care since the late 1980s. Yet they're ignored by people in the trenches who keep going back to just giving people what they want, which is a quick fix. Why wouldn't a person just want crack my back, poke needles in me, rub me, give me the laser, do some electrical thing, etc.? It requires the least amount of effort. Yet that's also the same thing that's led to the inactivity crisis. We're wired for conserving energy. As cave people, for survival, we had to go and find our food. As we had refrigeration and other advances of the modern world in the last 100 years, things are supersized at 7-Eleven on the corner store. We can have Uber Eats deliver stuff to us. We have a refrigerator. So of course we're wired to crave food, and now we have it all right at our fingertips. So it's a no wonder that we're overweight and we're underactive. So that's a double whammy. And now we have this gift. The silver lining is a gift. Let's take advantage of the opportunity that we have as a chiropractor, as a physio. We're in a privileged place to see people when they're suffering. I feel that ethically it is our responsibility to do more than give them what their preference is as far as treatment, but also to spend a little bit of extra time exposing them to fundamental movements, seeing how they move from a preventive standpoint, because we should be honest and we should tell people this is a recurrent problem. We're not fixing anything. What we want is to have the recurrences be less common. And we know we can lower the recurrence rate by 50, 60, 70%. It's still going to come back, but we can lower the recurrence rate. Well, that's huge. That's huge. And so what we should do is we should focus on these preventive things, not from a cure or fix standpoint. And we should partner with people. We should collaborate. So I don't care if they believe the narratives about health span and lifespan. I don't care if they believe the narrative that rehab is training in the presence of injury or pain. What I want to do is see if I can give them a positive experience with movement. I want to be an architect. I want to design an environment where they have fun and they're challenged. If they have fun and they are challenged, it's going to give them hope. Like, I must not be fragile. Look, I just did something hard. When you find the hardest thing they're safe doing, they feel like a badass. And that changes everything. So when I teach people two things. I teach them how to give a positive experience with movement. And number two, how to find the hardest thing a person feels safe doing. And we unpack that. That's it in a nutshell.
Yeah, it is.
People
And
love it, David. It gives them tangible hope and it gives them an achievable plan. That's my mission at LA Sports and Spine.
I couldn't agree more. I think when we're able to show our patients how they can feel as we expose them to different stimulus, oftentimes exercise, various movement patterns that maybe they thought that they would never be able to do again, and absolutely not doing within the presence of maybe pain or injury. It is incredible to see how people light up and how much more positive their outlook can become when we show them these things. And I really think that this leads to this point that I know you recently had Peter O'Sullivan speak to the group that you run, the community that you run. And I know one of your takeaways from his most recent talk was that we don't always have to change people's beliefs to change their behavior. And a lot of that comes back to potentially just showing them and giving them that positive experience so that we don't have to necessarily go down this path where we're spending, a long time, hours potentially with some people over the course of visits, trying to change their mind through communication. And I think this is something that was kind of a revelation to me as well, because we both understand the importance of communication and the importance of educating our patients and then guiding them through the experience. But if we're able to bypass that and not have to go through some of this difficult conversation simply by showing someone, I think there's an extreme amount of power in that. So as you begin to talk about these experiences that we're able to give our patients, and maybe for some of our patients that still, have not had these experiences or have not heard of these experiences when going to their healthcare providers, can we dive a little bit deeper into why it's important to include these therapies in people that are dealing with musculoskeletal pain? Yes, it's injury mitigation moving forward. Yes, it's improving their health span. But for those people that are still a little bit on the fence of whether or not I'm used to getting my back cracked, this feels good, it keeps coming back, but I'm happy about what's going on. Is there benefit for those people? And what would you say to them that would potentially change their mind of, okay, I want to find a provider that is going to give me more, that is going to consider more factors, that is going to improve my health span long term by taking me down this path of, okay, I want to maybe start to implement these more active strategies into care? How do we begin that discussion with our patients who are used to the opposite, which is really, as you mentioned before, just those passive therapies being applied to us to give us that temporary relief?
God, your questions just get better and better. That's the $1 million question. And I think that the key really is that we don't, because people aren't going to buy something that's for the future. They want something right now. People want instant gratification. And it is very hard to get a 24 or a 28 or a 31-year-old to listen to Warren Buffett and invest for the future rather than take that vacation to Cancun or go to that rave or that concert. Yet, I think people are not naive. People realize that there is this aggregation of gains that occurs if you at least invest a little bit in the long term. And so it's short term versus long term thinking, and it comes back to not focusing, as Peter O'Sullivan said, and I'm glad that you caught that. So much on what we derogatorily call pain-splaining. Don't focus on the pain science education. Focus on purveying the experience. And Ryan Chow said it best. He said, behavior won't change based on what we say. It will change based on how we make people feel. And if somebody comes in and they're expecting to jump on your table and be ministered to, because that's their belief system, and that's what they've had before, and it's helped before. Well, there's nothing wrong with starting there. But after I've taken a history, if I welcome them into the gym area, and the gym area is not a bro place, and I say, well, I want to assess you. This is a clandestine little trick of ours. We're assessing them. Everybody gets assessed before they get treated. Well, the assessment is the treatment, because we're going to assess their bending and we're going to see what they tolerate and don't tolerate. And then we're going to avoid the things that they don't tolerate, that they're afraid of. And then the other things that they tolerate, they may have a dialogue with us. Well, that's uncomfortable. And we'll say, well, the hurt probably doesn't equal harm. It's probably stiff. And they'll go, oh, okay. And so we start to see, how they interpret pain. And we can even use metaphors like a traffic light. Well, green isn't 0, green is 0 to 3. And yellow, I don't know. Yellow is like 4 to 7. We look both ways before we cross the street. And red is 7 to 10. I just look on your face and I see that you're withdrawing and there's fear. Obviously, we don't want to do any of those things. And people will tell you. And so we purvey that experience. And lo and behold, if you assess fundamental movement literacies, if you put people through body weight positions, like getting up and down from the floor, like rising from a chair, that's a squat. Going up and down from the floor, that is a lunge. If you slow it down and you get them into half kneeling and tall kneeling, if you go on all fours and you do a simple yoga move like a cat cow or a cat camel, you're identifying the bandwidth that they have. And you're also learning about their psychological state. You're learning if they interpret every hurt as harm. And this is all part of the assessment. And then they're learning about you. Are you some cowboy that's going to put them in positions that they're afraid of? Or are you respecting them? When they learn that you respect them and then you're exploring together to learn about their sensitivities, you gain their confidence, their cortisol starts to drop. And now all of a sudden you might even find things where they go, wow, why is that side different than that side? You might find asymmetries that are painless. And this opens up a lot of options. Really, at the end of the day, what we want is we want optionality. There isn't one way. There's many roads to Rome. And through this experience that we're purveying, that we're designing, it's an ecological approach. Lo and behold, now they've explored things in quadruped like a bird dog. They've explored like a side plank. They've explored a cat camel. They've explored tall kneeling and half kneeling and reverse lunges and sit to stand or squats. You may go back to what you started with, which maybe was a forward bend. And maybe the forward bend was sensitive. And now you repeat it and they go, wow, it's looser. And now they're looking at you and you've got them. Because they realized that they weren't fragile. And that was really your goal, was to show them that they're resilient. We want to bifurcate. People come in because they're fragile, or else they wouldn't come in at all. They would go, oh, it's just going to run a course like a cold or a flu. They come in because they're confused, they're worried about the future in the near term, and they have pending things like tomorrow or a week from now, and they're concerned about those near future things. And now you've just given them confidence. You've also done something where it'll come from them. They'll go, hey, should I be doing some of those things? So you don't even say it. You never say you should. I never say you should. I never call it homework. And you can go, well, yeah, that would be great, because the motion is the lotion and you don't want to get too stiff. So you start to now reinforce what they're starting to experience. You start to create what's called sense making. And it's a co-creation based on this experience. At the end of the day, we want them to have self-efficacy. There's no intrinsic motivation for behavior change until there's self-efficacy. Our job is to build confidence. And so we create that experience. Now, sometimes people are basket cases. And in a basket case, it's very easy to kind of stoke the embers. And they'll go, oh, it's getting irritated now. But for every one person like that, there's going to be 9 or 10 who go, wow, I feel looser. And in that one who says, oh, it feels more irritable right now, you go, well, I think we need to take it easy. We need to do less. And now they relax. And maybe you're doing one of Peter O'Sullivan's things at that point. All you're going to do day one is breathing exercises with them and give them what they want. So maybe you rub them. Maybe you give them heat. And those breathing exercises will be the self-management. So we find the safe starting point for everybody. And it's different for everybody.
Yeah, and I want to stick on Peter O'Sullivan here for just 1 second, because he has so many quotes that I think are applicable to this conversation. And one that I wrote down in preparation for today, I think really speaks to the points that you were just making. And the quote goes like this: and the most important skill I have learned is to listen to my patient's story, their concerns, fears, expectations, hopes, goals, their agenda. It's their dance we have to adapt to, not make them dance to ours. And I think this really goes into this conversation of what does it look like to take a patient-centered approach versus a more doctor-centric approach, right? And I think what the majority of people are probably used to is the doctor is leading the way. We're telling them, we're demanding that the patient do something to become better. And one thought that you just brought up that I thought was incredibly powerful was this idea that as we lead a patient through an evaluation, through an assessment, they begin to maybe come to these realizations themselves through the process. And one thing that I've always really thought was a powerful process within our patient interactions was when we could make the patients come to the realizations themselves versus trying to tell them what's going on. So when it comes to taking a more patient-centered approach, just to provide a little more context into what that might look like for somebody. One, why is it important that we go down that path? And two, what does that actually look like as we get into the clinical setting? How can patients begin to understand when they're in a setting where they're a part of the process, they're part of the decision making, and ultimately the practitioner is there to walk beside them towards their goals versus trying to drag them down a path that really speaks to maybe their intentions within care.
Well, as a chiropractor, if you're a good chiropractor, you're never dragging them. People have self-selected that they want an adjustment, and you're limiting yourself because you're only going to see the 10% of people in the population that want adjustments. Most people are afraid of a crack. And physical therapists are often, people are seeing them because the image is that they're going to give me exercises and they're going to do modalities. And, people like that combination that go to a physical therapist. But I think the Peter O'Sullivan quote is highly significant because we've underappreciated the history taking. And we call this narrative medicine. It's something even different from person-centered care or patient-centered care. The lived experience of the person is number one, and we have to allow space for the person to tell their story. So we'll ask a person when they first come in to please tell us their story. So tell me your story. And people will be kind of shocked. It's amazing that that's just not how things are done. People go, well, let me give you the short version. And I immediately, one of the only times I'll cut them off, I'll go, no, I want to, we have over an hour here. We have 90 plus minutes. Um, you can start wherever you want. I want to hear everything. Um, and we want to be passionately curious, to use Peter's phrase, to hear their story. This is something that's baked into an approach called motivational interviewing, where we listen with intent and we're going to reflect on what they say. We should be able to reiterate it and then seek confirmation that we got it right, and then ask if there's anything else. And this is all motivational interviewing, and it's not complicated, but it's not how medicine does things. An internist has 15 minutes. Not how chiropractors do things. Not how physios do things. Yet for us, it's really the only way. So we've shed any tethering to monetary concerns about transactional valuations. We want to do what's needed. We want to do what's right. And so it starts by listening to their story, validating their lived experience, identifying, as you said, their fears, worries, concerns, and goals. And this is a crucial thing for Peter in this surprising context where he says that we don't even need to change their beliefs to change their behaviors. We always thought we had to change their beliefs to change their behaviors. That behaviors can't change until beliefs do. But he said we need to distinguish between short and long-term goals. So a person comes in, I just want to be out of pain. Well, if we ask further, what we identify is we ask, well, what is it ultimately that you really want to be able to do? And they'll go, well, I want my life back. And they'll say it in different ways. That's how Peter says it. I want to get my life back. So however they say that, we want to identify what the loss is. If it's a chronic pain, their identity, there's a breach existentially in how they see themselves in the world. You will never really have success with this person. You won't have a long-term relationship with this person until you identify what makes them who they are. And if it's an acute situation, well, it's going to be easier because the habits aren't all broken. But it's the same thing. We want to distinguish between the pain and the function. What's the functional goal? What are the things that you can't do that you'd like to do? We always want to identify what matters to the person besides just symptoms. So we have a saying at LA Sports and Spine, it's on our logo, function better to feel better. I learned this from Dr. Carol Levitt. He calls it the functional approach. And the idea of the functional approach has sort of gotten polluted because we can't define it. But I feel, it's like pornography, right? Like we know what it is, you can't define it. Well, but I think we can. I disagree with most people out there that say you can't define function. Function is what matters to the person. Function is what is purposeful to the individual. So there isn't a generic prescription. But that I just gave it to you. That's the generic prescription. So we want to identify what matters to the person. And as Peter says, again, the sleight of hand of this whole experience is we focus on getting them to their goals. We determine what matters, we measure what matters, and then we program to change what matters. Something that Matt Jordan has elucidated in Calgary, working with elite athletes who are in a high stakes world of Olympic sports, especially snowboarding and things like that. And they've had ACL surgeries. But it applies to everybody. So I always want to validate people's lived experience, listen to their story. And from that, we'll identify the twin goals. This has always been what is part and parcel of the biopsychosocial model, is focusing on symptoms and function and explaining people that if we function better, we'll feel better. So yeah, there's a little explanation, but we're not telling them they should do anything. We avoid that way of talking or thinking. And the sense making is almost on the back end. The first thing is I give them a positive experience with movement. So they come to this on their own. Like, here are the things that are sensitive, and I'm on their side. I'm like, yeah, let's avoid those. So now they realize that I'm Alfred, and I'm supporting them. I'm guiding by the side. And then these are things that were neutral. And I'm like, hey, we'll get rid of rust that way. We'll get rid of stiffness this way. We'll promote circulation. The motion is the lotion. Your body will heal faster. So we're giving them the things that they tolerate. We're not telling them that it's no pain, no gain. It's never no pain, no gain. There is nuance. Not every hurt equals harm, but it's never no pain, no gain. So we're always reassuring them about that. But the idea that the motion is the lotion, I don't feel people have any problem with realizing that they should move. This is a boogeyman that people are saying, and then they double down, David. This is the worst thing that chiros and physios do. This is the real problem. And it's just as bad as the medical profession if they double down on the diagnosis based on an X-ray or an MRI or a CAT scan, saying you have degeneration or giving you these labels of a torn labrum or herniated disc, and therefore you shouldn't do X, Y, and Z. The chiropractor or physio who looks at the quality of your movement and says, oh, you're out of alignment, you have muscle imbalances, no wonder you have pain, your squat is off, you're moving improperly. These make people feel less than. And then they're afraid to move because they're afraid they'll do it wrong and they'll cause more harm. And I see so many people that don't want to move because they're afraid they'll make it worse. And they got that idea from a well-meaning personal trainer, chiropractor, or physiotherapist. I hate to say that. I hate to say that because we do so much good. But that is something very, very, very bad that we do. And in a world where there's an inactivity crisis that is so deleterious that it's led to a 20-year gap between health span and lifespan. And it also leads to like 50% higher recurrence rates for the very thing that we're supposedly treating well, musculoskeletal pain. Well, I rest my case.
Yeah, absolutely.
We have to change.
We do. We absolutely do. And I think when we look at the broader context of people's health and well-being, and then to bring that in with some of the comments that you just made as far as healthcare practitioners, often chiropractors, often physios, relaying diagnoses to our patients in a manner that scares them to be doing the things that they probably should be doing is ultimately having an extremely negative effect on so many people. And I'm sure you've seen this throughout your career where someone will come in having seen another practitioner prior and they begin to tell their story, right? Because we know how important this is to take the time to listen to our patients. And they said, well, the last practitioner told me I have this and I can't do X, Y, Z, A, B, C, D, E, F, G. The list just goes on and on, right? And
it's
I think
ubiquitous, David. It's everywhere.
It is. And I think to me, this is one of our bigger barriers right now is to have more practitioners be able to use effective communication skills so that we can empower our patients in the ways that you're talking about right now versus the opposite, which is telling people you can't do any of these things because of these diagnoses that are probably ultimately not having that large of an effect on where you're at. It's much more of these other things. It's the graded exposure. It's the movement snacks. It's getting people involved in valued activities that provide them with a sense of joy in their life. And for so many people that has been taken away.
Fun and meaningful.
Fun and meaningful. Yes. And so many people have probably get to these points where those things have been taken away because someone said, you cannot do this. It is going to make you worse without having a foundation to truly make that statement.
See, a chiro who says like you have a leg length inequality, this is not implausible. But the problem is it's a very nearsighted approach. It gets buy-in from the client. But in the end, it really is a ball and chain. No different than the physio who is prescribing a clamshell exercise when a person should probably be doing a Cossack squat. a lateral lunge or something like that. If we manage people away from load, then they don't feel like a badass. So we have to give them something fun and meaningful, but challenging. There's no change if there's no challenge. If there's not enough stress stimuli, we atrophy. And we have to flex that muscle, that badass muscle, so we start to feel resilient and robust. So I'm always chasing psychological resilience and physiological adaptations. The reason we get old young, the reason our health span doesn't last our lifespan, is because we're missing out on all these opportunities with musculoskeletal pain to explain to people that, we atrophy starting at 30 and your aerobic capacity is only going down from inactivity. So let's get you just effing walking and let's gradually build you up, because strength training, as an example, it's one of the pillars of the World Health Organization physical activity guidelines, is safe for 90-year-olds. So if it's safe for 90-year-olds, it's safe for 30 and 40-year-olds. And granted, I'm not going to give it to you when you're in acute pain, but I want to start to check these boxes of the general PA guidelines. So we want you to be doing 150 to 300 minutes of cardiovascular exercise. We want you to be doing twice a week of resistance training, and we can do it as exercise snacks. So it can be spread across the week if you got some kettlebells at home. And number 3, we don't want you to sit for hours on end. We want you to take breaks if you're sitting or standing. We want you to move a little bit during the day. Ideally, like every hour and a half of being still, you're gonna start to move. And if we can start to bring people up from 4,000 steps to 8,000 steps, if we can break up the day with more frequent movement snacks, if we can start to get people to not be managed away from load, then we can really help people have their cake and eat it too. They're going to become younger. I mean, who doesn't want to be younger? 50 is a new 30, 60 is a new 40. Like people love that message, but they're also very focused on the near term. If I'm in pain, I just want to get out of pain. So if they believe in dry needling, let's dry needle them. If they want soft tissue, let's do soft tissue. I'm going to assess them with movement. And so odds are they're going to gain access to what you just called the movement snacks, 5 or 6 minutes of stuff that I'll give them to do every 4 to 6 hours, because physiologically the window for adaptation opens every 4 to 6 hours. I'm going to have them do that. I'm going to support this through frequent touch points. Consistency and frequency precedes duration or intensity. So, and I'm going to support it. I'm going to give them my cell number. I'm going to use an app like True Coach. I want to guide by the side. I want to support the behavior change in a lot of ways. I want to create nudges for this, guardrails. This is all an ecological approach, David. I got to find what suits them. And when they've got these boogeymans like, oh, I'm afraid, my legs are off and I'm not activating my core, I'm not saying you don't need to suck your navel in or brace your abdominals. I'm not going there. I'm going to maybe focus on relaxation and breathing and other things. And then on the back end go, well, your body was actually bracing just fine on its own when you do these things. When you take a kettlebell, feel your core. Oh, it's tight. You see how it does that? There's a wisdom of the body to heal itself, to protect itself. It does it on its own. So if we overdo it, you wind up like this and your cortisol shoots up and your pain threshold drops. Now you associate every hurt with harm, and the hurt you feel becomes the feeling you hurt. That's not good. And they go, oh yeah, that makes sense. So when they say that makes sense from their experience, I know that I'm following an ecological approach. And this is so important for me to always be addressing the way they embody their pain, how it's enacted in their life, and to be as person-centered, listening to their story as much as possible. And I'm not the Batman. I'm not the hero. I'm always going to guide by the side. I'm going to shepherd the architecture to create safety first, and then to bake in fun and challenge and hopefully ecological validity through making it related to their goals. I'm a golfer. Okay, I got to get in a squat, a quarter squat. I'm a golfer. I have to be able to rotate. But when I rotate, my front leg is posted. I need internal rotation. Let's go into shin box. So you ask, like, well, what do? Well, I do this stuff. I look at them move. I find what they tolerate. And then the things they tolerate, we make a list, we shoot videos, we airdrop it to them. We send them a text with the list of the snacks. We make sure it's no more than 3 to 5 minutes of stuff. We say do it 3 times a day. That's what we do. That is what we do. We give them the things that they feel safe doing, that make sense to them. And everybody is different. But I have an approach where we look at basic stuff, stuff that isn't going to make anybody afraid. We look at their feet, we look at their mobility, we look at their pillar. This is not rocket science. And there's not one set of exercises. There's menus of each of these things to look at the afferents from the feet, to get their heart rate up thermogenically, to warm the body temperature up like in a beast crawl, looking at their mobility like a shin box or half kneeling or halos, looking at their pillar like planks, front planks, side planks. I don't care. Uh, Looking at their calves, looking at how they skip, how they store and release energy, how they come to a stop, how they land, a little hop. We see what's in their bandwidth, and we find trailers of coming attractions. A lot of stuff is for the future, but these things should relate to their demands. It's a gap analysis. We've listened to their story. We know what their goal is. It's golf, it's jogging, it's hiking, it's lifting grandchildren. And then we do an assessment to see what they have, what their floor is. And we want to bridge the gap from where they're at, from what their floor is to where they need to be. And that's what we guide by the side to program. And nothing could be more fun, and nothing makes more sense to people. And this isn't throwing under the bus passive interventions. So to me, that's a non-issue.
Yeah.
People have made mountain out of that molehill.
I agree. We've complicated it to the point where we make people feel like we're the ones that have the special sauce. We got the special hands, right? We're the ones that are going to fix you, the patient. When in reality, it's much more about this process of showing people that they can take care of themselves. They have the power to do so, and that we're very much there to show them and guide them down that path, right? So I know we could sit and talk
through the experience, like Ryan Chow said. It's not about what we say, it's about how we make them feel. So people like a chiro, a physio who does mostly passive care or corrective exercises, this isn't rocket science. Use the SFMA, use an FMS, do animal flow, do FRC. There's a lot of systems out there. Do DNS, do BackFit Pro, like have some sort of assessment. Learn strong first, kettlebell university. It doesn't really matter. I have a thing that I've developed. Peter O'Sullivan has a thing. Peter O'Sullivan looks at sitting, standing. He looks at you doing a bridge. He looks at you on all fours. And from that, he knows what he wants to do. You want to do orthopedic testing? Have them bend forward, bend backwards, bend sideways, turn their head, look over their shoulder, raise their arm, reach across, do this, do this. Like all of these things are windows. I'll have you beast crawl. I'll have you do a bridge. I'll have you do a plank. We shouldn't constrain artificially. What we should do is what you said, listen to their story passionately. And in their story, you'll know what you need to evaluate. If they want to play golf, I got to get them in a quarter squat. If they want to hike, I've got to get them in a like a split stance, like a lunge. If they want to jog, I got to get them on one leg and do a single leg squat. I've got to get them hopping and springing. Their story will tell you what tests. There are no special tests in orthopedics. There are no special screens in FMS and SFMA. Let the patient's story inform you. As Matt Jordan said, determine what matters, measure it, program to change it.
Yeah.
I mean, what is hard about this? What's hard is that we've all developed these systems that we're comfortable with, and I'm guilty. I did corrective exercises. I manage people away from load.
Me too. I've been there, and I think because most of us feel comfortable taking systems-based approaches, I think that's what leads to a lot of these constraints. We subscribe to these very specific ideas that lead us down these very specific paths that lead us to very specific treatments, when ultimately, as you've so eloquently put, it really is about really just listening to our patients, determining what their goals are, watching them move. As you said, the movement, the exercises, that's the evaluation, that's the assessment, and then determining the plan from there, versus within so many of these systems, the treatment is dictated by this very constrained approach. And I think that's where a lot of us tend to get lost, is because it simplifies the process for us, the clinician, to go down that path. When in reality, the process doesn't need to be complicated. As you've outlined, it really is a simple process. But I think a lot of this maybe is how we're taught as practitioners as we go through school, and maybe the lines of thinking of people that we've worked underneath. It becomes a challenge for those reasons. But
Well, David, I think it's very, very complex to integrate MDT, McKenzie system, with DNS, with BackFit Pro, with SFMA, with PRI, with ABC, XYZ. And what is often happens is, if you've invested in those things, you're no longer a sharpshooter because you've gone down the rabbit hole rather than looking out from the rabbit hole like Stuart McMillan from Altus suggests we should be. We should be generalists first, not go too deep, know about all these great things, because the marketplace has decided that they're all great. And I'm not here to say that they're not. But the real interesting little nuance, David, is that on the one hand, we want to hear a person's story. We have to validate their lived experience. We want them to feel that we've really heard them. So their unique goal, their very idiosyncratic history, because everybody's story is different, and then converge on something as general as the PA guidelines, which very few people are reaching. Maybe 50% of people are hitting the cardiovascular guideline. Maybe 30% are hitting the strength guideline, but only 18% are hitting both, let alone also the avoidance of sitting. So I know a lot of type A's. They do the cardiovascular, they do the strength, but they're stockbrokers and they work at a desk and they sit for 5 hours. Well, they just antidoted all the effectiveness of all that other stuff. So to hit the PA guidelines is actually very general, but the person has to feel that we've heard their story and that we're chasing their goal. Dr. Levitt had another great quote: "Don't be a slave of methods. The methods should serve the goals." And it's the person's goals. So hear their story, buy into their long-term goal. And for Peter, when they know we're focused on their goal, they become less worried about their symptom because they trust the process now. This is the mindset shift. When they know they're listened to and heard, then they don't worry about the micromanagement, nor do they get overly interested with, well, it has to get better by a week. Like, timelines enslave us. We don't always know the timeline, but there are landmarks. So we reverse engineer the goal achievement. Okay, this is a step ladder. Here are landmarks along the way. These are KPIs to your goal of running a 5K, running a half marathon, uh, uh, going skiing or snowboarding, whatever it is. I don't care. We make sense of the steps leading up to that for their injury, and focus on the landmarks more than the timelines. Focus on the functional landmarks more than the tissue injury or damage diagnosis or label. Focus on the functional steps and stages more than our system of passive interventions or modalities. It changes the whole conversation.
I know we could talk about this all day for several days consecutively without probably ever feeling like we're running out of things to discuss. But for the sake of our listeners on this episode, I think I want to end the conversation here with all of the great information that you've already provided, because I think there's a lot to digest here and a lot of questions might have been raised throughout this conversation. So are there any last thoughts that you want to leave the listeners based on our conversation today that you think might provide them with even extra value on top of the things that we've already discussed?
Sure. I mean, a lot of times I'll talk about, it's just these two things, make it fun and making it challenging, reassure and reactivate. It's helpful as we're leveling up, as we're updating our priors, to have these very simple constructs to hold on to. At its most fundamental, to help a person develop the self-efficacy, the confidence, and the intrinsic motivation for behavior change, for sustainable behavior change. What we want to use as a framework is, number one, we're identifying and addressing overprotection. And number two, we're identifying and addressing under preparation. And if you keep that in mind, you're going to get all these other things for free. So we identify when a person is in a cortisol, fear state. They're overprotective. Well, we want to downregulate that stress. And number two, we want to get upstream of the problem. Probably they were doing something they weren't prepared for. They did too much too soon or too little too late. So to Goldilocks it, we've got to slow cook through this landmark-based approach, criteria-based rehabilitation, getting them so that they are prepared, even over prepared. So there's a buffer zone for chaos, for the unexpected. And those two things are I think, a very powerful GPS for anybody, even if you're already doing this stuff. It just clarifies how it is that rehab is training in the presence of injury or pain. Look at overprotection, downregulate it. Look at under preparation, start to train it.
You make it sound so simple, and I love that. Craig, thank you so much for taking the time to talk with me today. I know our listeners are going to really take a lot away from this, and you've really provided them with a lot of value. So thank you so much for taking the time. We might have to continue this conversation down the road a little bit because, as I said, I know we can talk about these things a lot, and there's so much information that can be provided to help our patients who maybe are in positions where they're not sure where they need to go or what the next steps might need to be for them to get into this path, to find a provider that really considers them in the ways that we've discussed today. So thank you so much, Craig. We appreciate you. And to all the listeners, we'll see you next time.
Thanks, David.